Good evening, everyone. On behalf of the Bangladesh General Practitioners Association of Australia, or BGPAA, I am delighted to welcome you to tonight's webinar, Identifying Gaps in Implementing the National Lung Cancer Screening Program in Australian General Practice. My name is Dr. Reshmi Shehli. I'm a specialist GP with extended skills in skin cancer medicine and surgery, working in Melbourne. I'm also Education Secretary of BGPAA, and it is my pleasure to serve you as a moderator of tonight's webinar. Before we begin, I would like to acknowledge the traditional custodians of the land on which we gather today across Australia, and we pay respect to the elders, past and present. Now, let's briefly talk about our organization. BGPAA is a national not-for-profit professional organization representing general practitioners of Bangladeshi origin across Australia. Through education, mentorship, professional networking, and collaboration with RSCGP and ACRAM, BGPA is committed to advancing excellence in primary care and supporting the next generation of GPs, while also contributing to the development of family medicine and primary healthcare in Australia and also in Bangladesh. Now, coming back to the webinar topic. The introduction of Australia's National Lung Cancer Screening Program marks a major step forward in preventative healthcare and early cancer detection. As GPs, we are uniquely placed to identify at-risk patients and ensure timely access to screening and specialist care. Tonight's webinar aims to explore some of the practical challenges and opportunities in implementing this important program. We are privileged today to have an outstanding panel with us. I encourage everyone during this webinar to participate actively by submitting the questions through the Q&A function of the webinar. Our first speaker is Dr. Mahbuba Khanam, MBBS, MPH, FRSC GP. She is a general practitioner based in Liverpool, New South Wales. Dr. Khanam began her medical career at Prince of Wales Hospital and has over 15 years of experience in general practice. A passionate educator and college examiner, her clinical interests include women's and children's health, chronic disease management, and preventative medicine. Our second speaker is Dr. Daniel Wang, Biomedical Science Honors, MBBS FRSCP, Respiratory and Sleep Physician, and Director of the Lung Cancer Services in Canberra. Dr. Wang is a regular contributor to the multidisciplinary lung cancer meetings at Canberra Hospital and brings extensive expertise in lung cancer diagnosis and management. We are also honored to have Dr. Saidul Ansari, MBBS FRSCP, Respiratory and Sleep Physician and Senior Consultant at the North Canberra Hospital, joining us as our panelist for the discussion and the Q&A session. Thank you all for joining us this evening. Without any further ado, it gives me a great pleasure to invite our first speaker, Dr. Mahbuba Khanam. Dr. Khanam, the floor is yours.
Assalamu alaikum and good evening, everyone. Thank you so much, Dr. Sally, for the beautiful introduction. I am Mehbooba Khanam. I'm coming here from the Darawal land, and today I will provide an overview of the National Lung Cancer Screening Program and the critical role GPs play in its success. This program represents a major step forward in reducing lung cancer death through earlier detection. Lung cancer remains Australia's leading cause of cancer death. The biggest challenge is that many patients are diagnosed at a late stage when symptoms develop and the treatment options are limited. Evidence shows that low-dose CT screening can detect cancer earlier and significantly reduce the mortality in high-risk population. The National Lung Cancer Screening Program commenced on 1st of July 2025. It uses low-dose CT scans every 2 years for eligible high-risk individuals who do not have symptoms suggestive of lung cancers. The aim of this program is very simple: detect lung cancer before the symptoms develop. improve the treatment outcomes, and reduce lung cancer mortality nationally. Particular focus is placed on populations with a higher burden of the disease or the barriers to healthcare access, including Aboriginal and Torres Strait Islander populations, culturally and linguistically diverse communities, rural populations, and people living with disability and mental illness. To be eligible, patient must meet all these criteria. Be aged 50 to 70 years, be a current smoker or have quit within the last 10 years, have at least 30 pack per year smoking history, and be asymptomatic. Accurate pack per year calculation is therefore essential. Here is a simple way to calculate. If someone is smoking 1 pack a day for 30 years, or someone is smoking 2 pack 1 pack a day for 30 years, or 2 pack a day for 15 years. They meet the eligibility criteria along with the other 3 criteria. Patients with symptoms such as persistent cough, hemoptysis, unexplained weight loss, chest pain, or new shortness of breath should not enter the screening pathway. These patients require diagnostic investigations and appropriate clinical assessments. A useful way to remember is screening CT for the asymptomatic patient and the diagnostic CT for the symptomatic patient. The pathways and the clinical objectives are different. Screening CT is usually every 2-year routine interval. It depends on the result though. If there is a low risk, moderate risk, or high risk patients, then the screening interval change accordingly, and I will go through that later on the slides. GPs are the center of this program. Our role is to identify eligible patients, calculate pack per years, the cigarette smoking histories, assess the symptoms, discuss the benefit and the risk with your patient, enroll the patient into the National Cancer Screening Registrar, arrange the CT scan, review the results, and coordinate follow-up. It sounds like there are so many steps we need to do, but it's actually a very simple workflow for the GP. The workflow is essentially identify, assess, enroll, refer, and follow up. Simple. To improve the equity of access, existing CT infrastructures will be used wherever possible, and mobile screening units will provide services to selected rural and remote communities. I must say there is a very important practical point. Before requesting for the CT scan, the patient must first be enrolled into the screening program. So remember, referral alone is not sufficient. Enrollment only needs to occur once, after which the National Cancer Screening Register manage the reminders and the recalls. So most of us in the clinical softwares, we are using either the BP or the MD. They are directly linked with the cancer screening program. There is a dedicated hub where you can actually enroll the patient, register the patient, and fill in the form. It's very straightforward. The other way we can also do, we can use our healthcare provider portal through PRODA. Shared decision making is another mandatory part of this process. Patients should understand both the benefits, such as earlier detection and improved survival, and the potential harms, including the false positive result, incidental finding, anxiety, and of course, overdiagnosis. Smoking cessation support should always accompany the screening discussion. Every time we see a patient and when we discuss about these eligibility criteria or we enroll our patient to the screening program, it actually gives us an excellent opportunity at the same time talk with the patient about the smoking cessation program or the services available. Results are managed according to the National Lung Cancer Screening Program Nodule Management Protocol. Most of the findings will not be a cancer, but some patients will require surveillance imaging or specialist referral. One of the ongoing challenges for GPs will be ensuring the appropriate follow-up and navigating the surveillance pathways. Dr. Wong will discuss in details on this, but even though this looks a bit crowded slide, but just bear with me, it is actually quite self-explanatory. So if we go through this, you can see that we have actually divided the whole thing four categories: low risk, moderate risk, high risk, and very high risk. And it actually shows if there is a low risk or very, very low risk, then the screening will be every 24 months. From the low, moderate, and high risk, the main issue is the nodule growth. If there is a growth, then the management will be according to the high risk category reported by the radiologist in a structured report. And if there is no growth in the nodule, then the patient goes back to the screening pathway. If there is a high risk or a very high risk patient identified, then we refer the patient to the respiratory physician or other the relevant specialist linked with the lung cancer multidisciplinary team for investigations and management outside the program. Bottom line is, no lung cancer found, patients return to the screening. If there is a lung cancer confirmed, then patient goes to the respiratory physician and the patient exit the screening pathway. Interestingly, we will see that there are some additional findings which require some actions. One of the example, I would say, one of my patients who have gone through the low density CT scan, but interestingly, we found that the patient has quite a significant of coronary artery calcification, and eventually that patients end up having an angiogram and an angioplasty. So if there is any additional findings, that will be managed according to the relevant guidelines. Resources, there are excellent resources available for both the clinicians and the patients, including there are some dedicated materials developed by NATRU for the Aboriginal and Torres Strait Islander communities. I strongly encourage everyone to familiarize themselves with all of these resources. Especially, there are some CPD accredited healthcare providers e-learning modules with the Lung Cancer Foundation website. The government website has multiple program guidelines, and it's specifically designed for the healthcare providers, for the GP, for the nurses, and the practice managers. So wonderful resources available for the Aboriginal and Torres Strait Islander people separately, and please feel free to browse and go through, and those are very straightforward informations available. Now, there are some dedicated MBS items supporting this program. Item 57410 covers routine screening low-dose CT scan, while 57413 covers the interval scans when follow-up imaging is required. How can we support? There are several ways. A GP can actually prepare their center. Ensure, firstly, all the staffs are familiar with the program. They understand the smoking history accurately. They complete the available training program, establish the local referral pathways, and proactively identify eligible patients. It sounds like a little small actions in primary care, but it can have a significant impact in long run. Registration is very, very important. I can't stress it enough. Ensure your clinical software is integrated and staff have the healthcare provider portal access, and prepare the electronic medical record. You update and prioritize accurate recording of the smoking histories, and identify the local participating radiology clinic and establish a referral pathway with the patient who have the high risk nodules. I will finish with one simple key message. Unlike breast, bowel, or cervical screening program, lung cancer screening relies heavily on GPs identifying eligible patients. We are the front line of this program. While lung cancer screening may still be a relatively new concept For many of us in general practice, there are already excellent resources, training modules, and support tools available to help us to build our knowledge and confidently implement the program in our practices. The slogan for the lung cancer screening says it all. It's good to know. Yes, by proactively identifying high-risk individuals and supporting them through the screening pathways, we have an excellent opportunity to reduce the burden of lung cancer and save thousands of lives. So, it's always good to know before it's too late. Thank you for listening.
Thank you so much, Dr. Mahbooba Khanum, for your very nice and simple explanation into the screening program for lung cancer. Now, I would like to invite our second speaker, Dr. Daniel Wang, respiratory and sleep physician and director of the lung cancer services in Canberra. Dr. Wang will provide the specialist perspective on the lung cancer screening program, helping us GPs to identify the potential gaps between the primary care and specialist services and explore the strategies to minimize those gaps and discuss how to navigate actionable findings to ensure patients receive the timely and appropriate follow-up care. And I will now hand it over to Dr. Wang.
Thank you, everybody. Hopefully, I am sharing my screen appropriately. If there's any questions, please let me know.
It's all good, Dr. Wang.
We can see your screen.
Okay. All right. Once I present things, I will not be able to see people's reactions. So let me know if there's any problems. I'm just presenting from my work computer today. Well, firstly, thank you to the organizers for having me today. And thank you especially also to Dr. Mahbooba Khanum for such a clear presentation. I also like to give special thanks to Dr. Saido Ansari, who has always been instrumental from in my career from day one. Dr. Saido Ansari was actually my supervisor for my first term as a medical intern not too long ago. So it's a honor and privilege for me to present today, and especially as what Dr. Khanum has said early on, that GPs play such a crucial role in improving lung cancer mortality in Australia. Lung cancer is actually the fifth most diagnosed cancer in Australia, estimated 14,000 new cases, 9% of all new cancers, but it's actually the most common cause of death, of cancer death in Australia, 17% of all deaths. If you look at the 5-year relative survival of common cancers like prostate cancer, breast cancer, melanoma, that's sitting at more than 90%. If you look at colorectal cancer actually has a slightly, compared to lung cancer incidence, it's slightly more. But if you look at the mortality rate, lung cancer is 20% compared to 70% in colorectal cancer. Lung cancer also is disproportionately represented in indigenous Australians, Australians living in rural and remote settings, and people of lower socioeconomic status. The stage of which a lung cancer is diagnosed is crucial because the later stages are associated with very poor survival. If you look at the proportion of lung cancer diagnosis, depending on stage, you'll find that most lung cancers are diagnosed in stage 4. If you are diagnosed 10% before lung cancer screening program came in, about 10% of lung cancers were diagnosed in stage 1, of which the prognosis in orange is 68%. About 5% is diagnosed in stage 2, 32% survive 5-year survival. Stage 3, 8% of incidence, about 17% survival. And by far, the most common stage that for lung cancer diagnosis is actually stage 4, 45%. And you can see that the 5-year survival is only 3%. And this is based on 2011 data. And if you look in detail, you'll find that perhaps the stage 4 diagnosis is much higher than 45%, because we look at the number of stage unknown that we have found through our old data. It is likely that the stage 4, the proportion of lung cancer that we diagnosed, at least in 2011, was up to at least 50% in stage 4. So that goes about, some previous 2 or pivotal trials that look at whether we can actually detect lung cancer early on, and whether we can change the outcome and the prognosis for patients with who of which we detect lung cancer early. And there's 2 pivotal trials. That's the National Lung Screening NSLT trial in the United States, and then the Nelson trial in the Netherlands. The NSLT looked at patients between age 55 and 74 years, more than 30 pack year smoking history, current or 15 years ex-smoker. And what it did was that we looked at patients who were randomized either to a low-dose CT scan or chest X-ray. In the Nelson protocol, it looked at patients between 50 and 74 years of age, about 15 pack year smoking history, current or ex-smokers within the past 10 years. And it compared low-dose CT scan versus no screening. And you could see that both of these studies showed a 20 to 24% reduction in the mortality rate of lung cancer. And you could see that the incidence of lung cancer was higher in the screening group, which tells us that not only the lung cancer screening can detect it has better detection of lung cancer, it's also detecting in such a way that we can make changes and actually improve the mortality rate. Therefore, the Australian government underwent a scoping study, and afterwards we had a announcement of funding for the National Lung Cancer Screening Program, which commenced on the 1st of July 2025. And as Dr. Khanum has already explained, that it is for patients aged 50 to 70 years, have no symptoms or signs suggestive of lung cancer, a 30 pack year tobacco smoking history, current smoker or quit within the past 10 years. One of the most common findings that you'll see on an NLCSP scan is a pulmonary nodule. In fact, perhaps not just a common finding on NLCSP scans, or common finding on all CT chests. Dr. Ansari forwarded me some questions, and there seems to be a great interest to figure out, to understand in better detail regarding pulmonary nodules and what are some of the features that can indicate a higher risk of malignancy. A pulmonary nodule is defined as a small, less than 30 millimeters, well-defined lesion, completely surrounded by pulmonary parenchyma. It's important to note that the majority of pulmonary nodules are benign. Even in high-risk populations, the majority of nodules are benign. If you look at the PanCan BCCA cohort, of the 12,000 nodules that they screened, only 144 were malignant. So 1% of the nodules in this lung cancer screening cohort was actually malignant. And if you look at the patients with pulmonary nodules, how many of them actually had lung cancer? It was 144 of that 2,961 patients. So about 5% of the patients in this high-risk population with pulmonary nodules in the end who had lung cancer. There are many, by and large, the most common etiology for non-malignant pulmonary nodules is actually infectious granulomas, about 80% of benign nodules. And the other one will be hematomas, 10% of benign nodules. There's a very large differential diagnosis of non-malignant etiologies, whether the infectious, benign tumors, vascular, or other non-malignant etiologies like rounded atelectasis, peripheral nodules, rheumatoid nodules, and so on. In regards to malignant etiologies, the most common would be primary lung cancer, of which adenocarcinoma is about 50% of malignant nodules, and thereafter squamous cell carcinoma, 20-25% of malignant nodules. You could also get metastatic cancers and also carcinoid tumors as part of the malignant etiologies of pulmonary nodules. There are some features that make it more likely to be malignant, so increasing age, female sex, family history of lung cancer, emphysema, tobacco smoking, and asbestos exposure are some of the clinical features that are associated with higher risk of malignancy. The size matters in terms of the pulmonary nodules, and you can see the larger the nodule, the higher the malignancy potential, less than 5 millimeters, less than 1% malignant, 5 to 9 millimeters, 2 to 6%, 8 to 20 millimeters, 18%, more than 20 millimeters, more than 50%. In regards to the number of nodules, there's increased risk of lung cancer as the nodule count increase up to 4, but certainly when the lung cancer risk actually decreases when there are 5 or more nodules. The attenuation matters. Most nodules are going to be solid, but it's important to note that subsolid nodules that have which has a ground glass component or a part solid, part ground glass component, have a higher risk of malignancy, especially when they persist beyond 3 months. Having said that, for pure ground glass nodules, malignancy is still rare when it's more or less than 10 millimeters. And as discussed, part solid nodules have a higher likelihood of malignancy, especially when they are large, and also when they have more than 50% progressive solid component. So these are some other examples that you might see. This is a pure ground glass nodule, and we call this ground glass because it's more dense compared to the pulmonary parenchyma, but less dense compared to the vessels. This is a part solid nodule where you have 2 components of ground glass and also solid. And this is a solid nodule where you can see the attenuation is the same as the vessel. Growth of a nodule also increases the chance of malignancy, and growth is defined as greater than 1.5 millimeters in the mean diameter as per lung rats, or more than 25% increase in the volume of the nodule. And for subsolid nodules, when they have both when they are part solid and part ground glass, growth can also be identified as an increase in the development of the solid component. The rate of growth gives us a clue regarding the probability of malignancy, as most malignant nodules have a volume doubling time between 20 and 400 days. For other slower growing malignancies, such as a very low grade adenocarcinoma or carcinoid, they typically have a volume doubling time more than 400 days. And as the even low grade cancers you'll find, especially for the ground glass malignant nodules, they could have a volume doubling time of almost 3 years, 813 days. The location of the nodule also affects the malignancy potential. Upper lobe are more likely to be malignant, and peripheral is unlikely to be malignant. In terms of borders, speculation makes it more likely to be malignant. If you have a smooth border and presence of fat, that's a reliable indicator of a pulmonary hematoma, which is a benign lung nodule. And these are some examples of the nodules that you might see, so with different edges. So this is a smooth edge, this is a lobulated edge, and this is spiculation. So you could see the nodule and you could see spicules coming out of the nodule that often confers a high risk of malignancy. This is an example of a peripheral nodule that might look a bit worrying when you look at the axial scans, but actually when you look at the sagittal to coronals, you find that it's actually a flat lesion. This is a benign condition. Calcification, different patterns of calcification can indicate chronicity, and certainly most of the time it is attributed to a benign pulmonary nodule. Popcorn, central, laminated, concentric, or diffuse calcification are benign. There are some rare punctate and eccentric calcification that could signal some possibility of malignancy, but by and large, calcification is often a reassuring sign, especially for these patterns of calcification. We can assess the risk of malignancy on the initial scan using a PanCan and Brock model is often very helpful. And this model is based on that study that we discussed earlier on, the 2013 McWilliam New England Journal article that looked at over 12,000 nodules, and you can actually use this calculator, which is available on the internet, just utilizing age, sex, family history of lung cancer, emphysema, nodule size, nodule type, nodule in the upper lung, nodule count, speculation, to assess the individual nodule on its malignancy potential. There are limitations to this calculator, but the reason why it's used widely and also as part of our National Lung Cancer Screening Program is because all these parameters you could get on the CT scan. And if you look at the only clinical history that you need is this family history of lung cancer, and you can actually have a quantificate. You can actually quantify the percentage of malignancy risk based on these features. The NLCSP nodule management of the baseline CT, Dr. Kanum has already went into detail, and I won't repeat it, but essentially it categorizes the nodules based on risk, the lowest risk being category 1, where you often have a pan-scan score of less than 1.5%, or which you just have to have a repeat CT scan in 2 years. If you have a category 2, a pan-scan score between 1.5 and less than 0.6%, is a 12-month low-dose CT scan. The category 3 lesions have a risk between 6 to 10%, and they have a repeat CT scan 6 months. 10 to 30% risk is category 4, repeat CT scan 3 months, and more than 30% category 5 and 6, they'll ask you to refer to MDT. If you have a category 1 lesion that is stable, or category 2 lesion is stable, or 3 or 4 is stable, you'll find that they specify the intervals for repeat CT scan. And if the nodule is growing or new, the management is determined by the morphology. And you'll find that when you look in detail, it gets more complicated than just a pan-scan score, because they introduce different morphology of nodules, such as the atypical pulmonary cysts or even airway nodule, that each of them have a different management protocol. One of the other questions was about incidental findings from the group. And what you found is that when you look at the NLST data, 34% had a significant incidental finding on at least one screening exam. Emphysema was actually the most common incidental finding, 43% in this study. And coronary artery calcifications, 12%. So those are probably the two most common incidental findings. But you can get various incidental findings. If you look up the NLCSP guideline, you'll find that there's a few pages long of guidelines that's been provided by RANSCA to the reporting radiologists on how to report incidental findings. And they do try to be helpful as much as possible. And they even specify certain things for when they're making recommendations, often whether it is clinical review according to guidelines, or they might also say refer to specialists. For example, in interstitial lung abnormality, you'll find that if the radiologists find an interstitial lung abnormality with high-risk features that's defined as whether it's honeycombing, reticulation, or traction bronchiectasis, or they see progression between scans as the patients go through their repeat CT scans and they find progressions of the interstitial lung abnormality, they will recommend clinical review of the symptoms, family history, crackles, perform a HRCT chest, and refer to a respiratory physician. So if you look up the NLCSP additional finding guidelines, they goes through each incidental potential finding that you might find, and there are recommendations to in the report regarding whether to clinical review, certain tests that you should perform, and whether you should refer to a specialist, or what guidelines you should use to manage the incidental findings. This is the story in Australia so far. This is based on a 16th of March update. As of 16th of March 2026, there was 73,000 participants enrolled into the program, and more than 70,000 low-dose CT scans that were completed. And we are currently enrolling on average 288 new patients per day. And so thank you so much for all your help and assistance in referring these patients. In fact, the latest data from May suggests that we've now hit more than 90,000 of low-dose CT scans completed. This is what we're trying to prevent. This was a patient that I saw in 2022 who had 8 weeks of cough, and by the time that she came to see us in clinic, you could already see that she had a bright lower lobe nodule that is very FDG avid. You could see a mediastinal lymph node that is very FDG avid, and crucially, this is stage 4 disease with this very FDG avid lymph nodule. And in contrast, the whole goal of the National Lung Cancer Screening Program is to actually detect lung cancer early. This is actually one of the first cases that we saw at the Canberra Hospital. This is a 68-year-old lady that the GP correctly identified met criteria for the National Lung Cancer Screening Program. She underwent a NLCSP scan, of which they detected this right upper lobe nodule. Thereafter, she was referred to us on the 19th of August last year. She had a PET scan on the 26th of August. She was reviewed in clinic on 29th of August with lung function testing. She had a CT guided biopsy on the 3rd of September and had successful surgery at the Canberra Hospital on the 19th of September. Now, it's not always that easy to line up and coordinate care for patients, but this is just one of the success stories that the National Lung Cancer Screening Program has come about because of the National Lung Cancer Screening Program. But you appreciate also that sometimes it's not always easy to coordinate care, especially from a respiratory perspective, because oftentimes you're trying to liaise with medical imaging, surgeons, you're trying to organize sometimes you might be trying to organize a bronchoscopy and endobronchial ultrasound, or even and also the function testing. And oftentimes, especially at Canberra too, we are often trying to organize accommodations for patients who actually travel from South Coast or go into a hospital for care. Some of the other questions that Dr. Ansari mentioned that was provided to me included how should borderline eligibility patients be approached, and given that there is some subjectivity to the calculation of PEP years, and not to mention also sometimes in patients of different cultures, they might smoke tobacco in different ways. Sometimes they might smoke tobacco that they rolled by themselves. Sometimes they might smoke tobacco through bongs or even shisha, among different things. I think as long as you can hand on heart say that, yes, I think the PEC year is about 30 PEC year, then those patients can be enrolled into the NLCSP as long as they don't have any new symptoms and they don't have and they have either stopped smoking or quit or a current smoker within the past 10 years and they're aged 50 to 70 years. When should PET scanning be considered? Generally speaking, the most patients who have a category 5 and category 6 nodule who are referred to respiratory physicians for those high-risk nodules would be eligible for PET scan. The question mark, of course, is regarding logistics. I understand that there might be some limitations with MBS. Correct me if I'm wrong. There may be some limitations with MBS funding for GP referrals for PET scans. I'm not sure whether that's still the case, but certainly at the Canberra Hospital anyway, when we review the referrals from GPs, if they are eligible for PET scan, we order one for them before they first review with us. And what's the local referral pathway for suspicion nodules? They differ for each jurisdiction. The only requirement for the National Lung Cancer Screening Program for referral of category 5 and category 6 nodules is to a respiratory physician who is linked to a lung cancer MDM. So that's most most respiratory physicians and also tertiary hospitals that with a respiratory program. The good question is, how should anxious patients with moderate risk nodules be managed? So if they have a moderate risk nodules, the recommendation would be having a repeat CT scan in 3 months. And how should those anxious patients be managed? I think it's the reassurance to them that if it is a lung cancer nodule, it'll still be detected early, and that the repeats it'll be very important to repeat the CT scan at the 3-month mark so that we can understand its growth before we to fully understand its malignancy potential. So I think it's a reassurance that that this NLCSP lung cancer screening program has been developed based on the lung cancer screening studies that were done, and that following this protocol of repeating the scan at the timely intervals will still help you detect lung cancer early. So some conclusions. Lung cancer is the leading cause of cancer-related death in Australia. Lung cancer screening helps to detect cancer at an earlier age, at an earlier stage. It contributes to higher survival rates and improved quality of life. It reduces the number of patients who need treatment for advanced stage lung cancer. And again, remembering the NLCSP eligibility, 50 to 70 years old, no symptoms or signs of suggestive of lung cancer, 30-pack-year tobacco smoking history, current smoker, or quit within the past 10 years. The other question was about how we can encourage uptake in the NLCSP. And I echo Dr. Mahbubah Khanum's thoughts that really GPs play a pivotal role compared to breast cancer screening or cervical cancer screening. It really is a GP who performs could identify the targets for the NLCSP. There are a few ways that we could try to actually improve uptake. Perhaps we need to definitely be more opportunistic and systematic in identification of eligible patients. We need to figure out a way to ask and standardize smoking history documentation in GPs and also in specialist areas. And certainly, if I see a patient in hospital that I'm seeing, for example, for COPD, and they're eligible for NLCSP, I write a letter to the GP and also to the patient to tell them to enroll in the NLCSP at their GP visit. We should need to consider whether there's ways we can embed prompts in digital health records. If there's a way, if we're partnering with the multiple good digital health record systems that GPs currently use, and that way if we can enter in the smoking history pack here for the patient, we possibly could identify patients who could be eligible for NLCSP just using our own digital health records. I think we need to also adjust the language at times in terms of how we are speaking to patients for the NLCSP. And so proactive and clear recommendations could help, such as lung cancer screening is a proven way to find lung cancer early when it's most treatable. And we also should normalize and destigmatize screening. So this is a standard preventative care that we do for our patients. Right? And we should reduce practical barriers. Sometimes, if there is a way to do an e-referral for a patient, that could reduce a practical barrier for the patient calling the radiology place to actually book in the scan. And always remember to link screening with smoking cessation support. Again, I think the most critical thing to take away is the important role GPs play in this fight to reduce lung cancer mortality, all the way from identification of the patients who will be eligible to actually providing smoking cessation report and the follow-up following an NLCSP scan. That's all for my presentation today. Thank you for listening.
Many thanks, Dr. Wang, for your invaluable insight into this screening program. And we came to know that how GP plays the pivotal role in this early detection of lung cancer and save people's life. Thank you so much for the referral pathway explanation. It becomes easier for us to understand now what should be the way to go. Now, I would like to request Dr. Saidul Ansari, respiratory and sleep physician and senior consultant at North Canberra Hospital, to join us as our panelist. Dr. Ansari will lead the discussion and the question and answer section, addressing the question from the audience of tonight's webinar, as well as the selected topics from a curated question bank that we have at hand. Together with our speakers, we hope to provide practical insight that will assist our GPs in implementing this screening program in everyday practice. I will hand it over to Dr. Saidul Ansari, please.
Thank you very much, Dr. Sahli. I am going to say with a note of thanks that thank you again for organizing the presentation, and Dr. Wang to have such a concise and targeted presentation. Now, in terms of question and answer session, I may ask my one question before I go to the other questions. The last question I added is actually mine. Sometimes we get radiologist who has done the lung cancer screening CT, and then they have another scan like coronary care. Coronary is a CT coronary angiogram. And the same radiologist is reporting same nodule in two different ways. So this question I would like to ask to Dr. Wang. I know I do tackle it my own way, but I'd like to hear your opinion.
Thank you, Dr. Ansari. I think that's like two separate questions. I think there's one where sometimes it's a nodule that is reported in two different ways. That's firstly. Sometimes also it is nodules that are detected at different time intervals, but not compared by radiology because of either they were done at a separate radiology place, or sometimes the radiology service didn't detect that it's the same patient. And that's a systemic issue for two things. Number one, we don't have a central repository. And number two, we don't have easily ways in Australia to identify the patient because we don't have unique identifiers. Sometimes patients go by their first name, sometimes they go by their middle name, sometimes they go by their nickname, especially for first name. Sometimes radiologists can't link it correctly. So I think it's a real issue when the radiologists are unable to compare the previous scans because they're not available or not detected. But going back to your initial question about what to do when there are discrepant reports regarding the same nodule in a relatively short period of time, I think what you find in the nodule management protocol, even though we like to think of it as quite clear and obvious, in medicine there is shades of gray depending on how you interpret the nodule. Remembering also that a lot of times with the nodule, that depending on how you slice the nodules, you might get slightly different dimensions each time that you measure it. And also, there is differing clarity when there's contrast and non-contrast, and depending on which scans that you might use, especially when you're using a coronary artery, when you're performing a CT coronary angiogram, you actually you often sometimes don't even get the entire part of the lung parenchyma. So I think when there is the most important take-home point for me is that when there are discrepancy, the most important thing would be to actually talk to the radiology provider to notify them of the discrepancy so that they can actually also have their own system to check their own system to prevent this in the future. And if there are also problems, to also if you are attached to a particular hospital, to bring it up in your multidisciplinary meeting with radiology so that your internal radiologist can compare those scans. That's how I would approach it.
Thank you very much. That was a very elaborate and targeted answer. Now, online, looking at online questionnaire, we have a question: will emphysema treatment reduce the lung cancer risk? Look, I would like to take this on. I guess the answer is in the question itself. Yes, emphysema treatment, if the patient, if the case, index case of patient can reduce or quit smoking, yes, will reduce the risk. Apart from that, we need to be mindful these days that smoking doesn't just mean that cigarette smoking or tobacco. There are other forms of smoking, including vaping. These and the risk needs to be managed comprehensively in that sphere. Treatment of COPD itself, I'm not aware of any data that it reduces the risk, but it is beneficial in a way of managing patient in a holistic way. And my general practitioner colleagues are in the best place of doing so.
So, Dr. Ansari, should we go to the question bank questions? There are some questions that we figured out from the question bank. So there were the first question was, which pulmonary nodules should concern GPs the most?
Dr. Wang, you have touched upon this. It will be rehearsal, but
yeah, correct. So I think the National Lung Cancer Screening Program makes it quite easy that you refer all category 5 and category 6 nodules. And the category 1 to 4, you just got to monitor, right? I almost wish that we could come up with such a protocol also for our non-national lung cancer screening program. I guess if it's outside that program, then certainly certain features might make you more worried. And in regards to things like speculation, the size of the nodule, whether there's any interval growth, whether there's speculation or whether they're in the upper lobes, and the radiologists will often give you a guide about how worried it is, whether they recommend monitoring or a referral to a respiratory physician. But the National Lung Cancer Screening Program actually makes it quite easy that the category 5 and 6 nodules will need to be referred, and the rest of the nodules just got to be monitored.
Thank you very much. There was the second question, what incidental findings are commonly seen? I think you have actually explained a bit of it already.
Yeah, it really is emphysema and coronary artery calcification. That's probably the most common, but you have a lot of different things too, including things like bronchiectasis, institutional lung abnormalities. In addition to that, you might find mediastinal lymph nodes, some atypical mediastinal cysts, among different things as a whole list. But the top two most common will be emphysema and coronary artery calcifications.
Okay. And which of these findings will require urgent referral, you think?
Yeah, this is where I think the National Lung Cancer Screening Program is also quite helpful. So it's very established guidelines about what conditions require clinical clinical review, and also what will require for the investigation and what will require specialist referral. The National Cancer Screening Program has actually protocolized it, and often they will even give you the guideline to refer to for each condition. Understand sometimes it's not like medicine, sometimes it's not 100% clear cut, but they do try their best to standardize the recommendations to GP to help you know when you should send a specialist and when you should do review according and management according to guidelines.
Thank you very much. I think you already explained when should PET scanning be considered. Usually it's a specialist who refers for the PET scanning you mentioned. And what are the standard surveillance intervals? So you said 3 months?
Yeah, I think myself and also Dr. Mabua kind of actually touched on that. Really is the intervals of repeating the scan it depends on the risk of the nodule. So depending whether you're category 1 or 4, the monitoring intervals would range from 3 months to 24 months.
Okay, thank you. I'll go back to Dr. Ansari. Dr. Ansari, would you like to put any questions or discussions towards the speakers?
Okay, I think there are a few other questions which we have touched upon already. One of the questions is, are lung nodule clinics available in locality? I think we have answered this. Dr. Wang has answered this. Every jurisdiction has such service, but I would like to touch upon this. For our GP colleagues who are in remote locations, they also have sort of spoke and hub model reaching to the tertiary service, and they should be able to refer the patient to that service as far as I'm aware of. One other question I think a couple of my colleagues, GP colleagues, asked that for incidental findings, how to refer the patients. I would like to answer this question in a way that it is a kind of clinical need basis. Like if you find emphysema and a patient in front of you do not have significant impairment with it, starting with the spirometry, smoking cessation, vaccination, general health, risk reduction, and if you have done the guideline-based management and then following them up, and then you have issues in their management, you can refer one. In terms of coronary artery disease finding, which is the other commonest finding, I think best thing for in the general practitioner setting is again review the patient clinically, which you do, and then if you have concern that this patient in front of you needs some kind of functional assessment with either physical or pharmacological stress test or cardiology review, you refer them on. That were the two other questions sent to me. There were other questions in terms of access to bronchoscopy. Given Dr. Wang is the clinical lead of lung cancer service in ACT, I'd like to ask Daniel to answer this question.
Yep. Again, great question, I must say. Let's be very honest and say that this screening program, firstly, great initiative, but are there still problems? Absolutely. It's not just access to specialists, but also access to GPs, right? Sometimes, there are locations and geographical and also financial barriers to access GPs. There are also financial, geographical access problems to also specialists. And this is not necessarily unique to lung cancer screening. Let's just think about bowel cancer screening. You might do an FOBT, and sometimes trying to go through the public system to get a colonoscopy is not the easiest thing. So are there barriers? I'll be very honest. Yes, there's absolutely still barriers for access to specialists and to specialized procedures. Let's remember also, as the National Lung Cancer Screening Program, as much as the funding has gone towards establishing a service and also establishing Medicare items for bulk billed CT scans, a lot of the funding, a lot of there's no necessary additional resources for GPs and specialists to actually implement this program, right? And so, there are systemic barriers that still exist, and each jurisdiction and local your own geographical region has its own specific challenges. And that's I think an opportunity for us to actually voice any concerns that we may have, that as you see your patients in your daily practice. And the other important point for us doctors is the advocacy that we need to have, especially if we identify such challenges. And I think the challenges for each region will be quite unique and different. For us in Canberra right now, we have organized our rapid access clinic in Canberra Hospital to take in all the national lung cancer screening referrals, of which we are, in addition to the high-risk nodules that you detect, not part of the national cancer screening program. And while we are able to, at the moment, see all national lung cancer screening program within 16 days, our median 16 days of referral right now, the amount of referrals are climbing. And on top of that, it's probably the lower risk nodules that are not part of the national lung cancer screening program that we might be starting to see a backlog of. But that's a access problem that all we can do with limited resources to triage. And certainly for us, the National Lung Cancer Screening Program patients are, if positive, are already at a higher risk, and so they are prioritized for review. And then there's also issues with PET scanning, right? Because then all our patients get PET scans before their appointment with us. And right now, I think our wait list for bronchoscopy is we're sitting at about 30, of which we probably do 3 to 4 lists a week and have 3 to 4 patients per list. So there are, I will be honest and say that I think there are still challenges. And I think as clinicians, as we identify them, we've got to find our local solutions and also advocate for our patients and for more resources. But I suspect that while everywhere has shortages of resources, some places are probably disproportionately affected. And if there are any particular challenges, I think we need to advocate and certainly reach out, and maybe we will have a better voice when we are united. And especially this organization like BGPAA, I think could be a good place to advocate, especially if you're finding clear systemic issues with access.
Thank you very much again for the elaborated answer. Similar question asked for access to pulmonary function. I suppose this is in the area of same issue of funding and accessibility. And again, I would approach the same way, keeping in mind that general practitioner colleagues are at the best place to access spirometry service. And additionally, if we need to refer on, again, depends upon the clinical need and patient in front of you. Respiratory physicians, we have our challenges in all the department, but we try to prioritize with the depending on the clinical need. In this area, Dr. Wang, any comment how we improve the access from our GP club?
I think GPs are the future. So I think that non-function testing access, if that's something that we can actually implement in general practice, that will be something. Number one, you're going to be detecting not just COPD earlier. You could provide better care for any airway disease, whether asthma. What is not perfect right now is adequate financial compensation when billing for spirometry, especially for GPs. If you look at the way there's more and more regulation about how spirometry should be performed, considering also since COVID, right? You've got there's certain specifications about how many air exchanges you need, the amount of cleaning you need to do between cases, and not to mention for GP practices, that means maybe a consult room quarantine off for lung function testing, when otherwise you could easily put in another GP associate in there to perform clinics for 5 days a week. So if we are serious about improving respiratory function testing, and in a way that is performed in primary care, it is currently not sustainable. And so the only way forward is to advocate for better billing in regards to spirometry. And right now, I think to make it work, it's sometimes from a business perspective, you might need to charge a gap just based on the current Medicare items. But long term, if we really want to improve access to lung function testing for the community, I think it needs systemic change, especially in regards to Medicare billing. If I'm going to be honest, that's the only way that I see it happening.
Thank you very much. Look, time-wise, I think we are just over 8 o'clock, and I would like to hand over to Dr. Sally for any other question or any concluding remarks. Thank you.
Thank you, Dr. Ansari. And I would like to take the opportunity to thank you all our excellent speakers, Dr. Mahbooba Khanum, Dr. Daniel Wang, and our panelist, Dr. Ansari, for running this webinar, which helped us immensely to clear up our confusion about the lung cancer screening program. And I'm sure that from now onwards, we are better prepared to face all the challenges in this program and help our patients to detect cancer early. Before we conclude, as you can see on the screen, our participants of tonight, we would greatly appreciate your feedback, and please complete the evaluation form by scanning the QR code displayed on the slide that you can see now. And a link to the evaluation form will also be emailed to all of the attendees of tonight's webinar. And those who require to complete the measuring outcome activities, please remember that this should be undertaken within 3 weeks of following tonight's webinar. So by that time, you have to finish up your measuring outcomes activity. If you are unable to attend the live session of tonight's, would like to revisit the presentation or you would like a recording to be available, it would be available on the BGPA YouTube channel, and participants may self-claim the relevant CPD hours in accordance to the RSCGP requirements by yourself. Thank you. And finally, the attendance certificate for tonight's webinar will be emailed to all the registered attendees following tonight's webinar. Thank you once again, all of you, to participate, and to on behalf of BGPA, I would like to thank you all again. And we hope that you find the session quite informative, valuable, and we look forward to welcome you again. Thank you very much for being with us.
Thank you.